Hi, Miranda. My name's Kate. I'm going to be your night nurse. You don't look like you're feeling so well.
I am not feeling well.
Tell me about that. What brought you in tonight?
I have the headache from hell.
Really?
I
Okay.
just don't feel good.
When did the headache start?
Probably last night. And I took some Tylenol, but it just didn't help. I tried to sleep and it just didn't go away.
Okay. What time last night? Do you remember about? Was it like getting ready for bed, 8 o'clock?
Probably around 8 o'clock.
Okay. Has blood pressure at all been an issue for you this pregnancy?
Not really.
And how far along are you today?
I'm like 36 weeks.
Okay. Any previous babies? It looks like maybe you've had 2 previous babies.
Mm-hmm.
Okay, so this is your 3rd.
Yeah.
Congratulations. So maybe we can get you to feel better so that you can enjoy the rest of this pregnancy.
I think I'm gonna be sick.
Oh, okay. All right. Let me get you a bucket. No, we're gonna pretend because I don't have any in this room. Here, hold this just in case. And I'm gonna turn the lights down.
Oh, thank you.
How's that?
So much better.
So the light bothers the headache?
Definitely.
Okay. Have you had any pain in your upper right side specifically, but like unrelated to where the baby's pushing?
Not really aware.
Oh. Okay, so that is painful.
Yes.
Not the same over here.
No.
Do you mind if I feel your belly? Okay. No pain really? Okay. All right. Who do you see in the office?
Dr. Bob.
Okay. And did you call in before you came?
I did.
Did you speak with him directly?
No, I think it was somebody else on call.
Okay. All right. So I'm gonna just ask a few more questions, get some vital signs on you, do an assessment, and then I'm gonna go talk to Dr. Tardif. Okay.
Okay.
Okay. So we have epigastric pain. You have a headache. Any changes in your vision?
Sometimes I see little stars, but not all the time.
Kind of like things floating in the way?
Yeah.
Okay. Any darkening on the sides?
No.
Okay. Have you had any swelling this pregnancy?
I can't get my rings off.
Okay. All right. So it does look like we have a little bit of swelling. Is the swelling in your legs the fact that I push in and it kind of stays there for a while? Is that new to you?
Yeah.
New within the last day or two?
Probably.
Okay. All right. Any bleeding?
No.
Vaginally leaking of fluids?
Not that I'm aware of.
Okay. Any nausea or vomiting?
I definitely feel nauseous, but no vomiting.
Okay. Any trouble breathing? Any cough?
No.
Fever?
No.
Any trouble with your urine? Does it hurt to pee? Any extra
I feel
discharge?
like I'm peeing all the time.
Okay. All right. So, do you have to pee right now before I get on the monitor?
No.
When you do have to pee, please ring the red button on your call bell to let me know because I am going to catch some urine and probably send some labs out of that. Okay.
All right.
There's probably going to be a lab tech come up soon, take some blood.
Okay.
All right. Is there anything I can get you right now that would help the way you're feeling?
If you could get me something for my headache, that would be great.
Okay. Do you mind if I get some vitals and listen to your heart and lungs?
Sure.
Okay. So on this patient, we're already seeing a picture of what could be preeclampsia. So because of the headache, the visual disturbance, the epigastric pain, the swelling that's new onset, and the nausea, I'm going to be listening for heart and lung sounds. This will give me a baseline to make sure over the next few hours if anything changes with the lung sounds, okay, specifically. And then also I'm going to do a head-to-toe assessment. I'm going to get a set of vitals. We're going to check serial blood pressures on this patient since it could be preeclampsia. If the automatic blood pressures are high, elevated, we would do manual blood pressures. If the automatics are not elevated, I probably would not do a manual blood pressure unless asked by a physician. But here at practice at St. Mary's, if a patient comes in with preeclampsia symptoms, you pretty much know you'll be doing manual blood pressure, at least to get your baseline. So I'll do automatic. If it comes back completely normal, I may do a manual just to double check. Can't really trust machines. But some people with preeclampsia have normal blood pressures. It's probably more common to see elevated blood pressures, but you don't always see that with preeclampsia or HELLP syndrome. The signs of the liver mean we're going to, I mean we would anyway, but pay special attention to whether or not the AST and ALT are normal, the platelets. Liver involvement can mean HELP syndrome, which is even more acute than preeclampsia, and so we want to be paying good attention to that. Seizure precautions, if I think this patient has blood pressures that are in a severe range and she already has severe symptoms, again, lowering the lights, I'll shut them off when I leave the room, even if she'll tolerate that. Keeping the noise and the stimulation down. If she's on her phone, I'll tell her, you know, it would probably make you feel better, lower your symptoms if you just put the phone away for a few minutes. And we'll let her rest quietly. Cold cloth, if she's nauseous, we can get her nausea meds quickly probably, get her a bucket, anything that would make her comfortable, maybe a fan. And then if there's severe range pressures, we want to contact a provider and get them up here to see her very quickly. That might mean pushing an IV medication called labetalol. We might do, is that hydralazine? Oral. And then there's another one we do oral. There's like 3 medications here that we might give. 2 of them are oral, 1 of them's IV. And so I'm gonna listen to heart and lung sounds. If lung sounds are clear now, you wanna make sure that they stay clear throughout the process of preeclampsia. You might get pulmonary involvement if the fluid shifts. And then we're going to do, again, I already checked the swelling, but we would also do reflexes, deep tendon reflexes, and clonus check. So I'm gonna show you what that looks like. Is that okay? So I start with uppers. So I ask them to give me all the weight of their extremity, and I use my thumb on the very obvious tendon in their arm. And then I go ahead and let the arm dangle. And did you see the hand jump a bit? So then I'm gonna ask you to go ahead and give me the weight of your leg. And I feel right below the patellar bone, you feel for the little indent. Brisk reflexes. She's not even faking that. So again, giving me all the weight of the leg. Sometimes I jiggle a little just to have them relax it. And then checking for clonus is putting your hand on a foot, and I like to just kind of like let them loose and relax, and then without them noticing what you're doing, press upward. And then what you're looking for is pedaling. So I'm gonna pretend with your foot, but if you were to be getting clonus, you would count that in beats. So if you pushed up and it came back, you would see it go down in little beats, okay? And you'd count the beats. So it could be like 1 beat of clonus, 2 beats of clonus, and upwards. If you used the hand, which I'm not wonderful at, but I've seen done, you would again make it loose and relax, push it back, and then look for beats of clonus. And people that are really ready to seize, they have beats in their hand of clonus when you check. So I would do that assessment, listen to heart and lungs, and then because she seems like she's having severe symptoms, and based on what her pressure is, I would go right out, shut off the lights if I can, get her some cold water, and contact a provider right away. Now, based on what comes back, would decide what you do. You want to be ready in this patient to start an IV quickly. We up here, we draw labs off our IV when we put them in to save them from a second poke. So you want to be ready for what labs you'd be getting. In a patient that we're worried about preeclampsia, we'd be doing a CBC, a type-in screen, a CMP, and a liver eval, liver panel. We would also want a urine because we want to check the urine protein creatinine ratio. Anything above a 0.3 is diagnosable as preeclampsia in that protein creatinine ratio. If it's not there, but there are severe symptoms, it doesn't necessarily mean that they're not going to diagnose her, but they may have her do a 24-hour urine. Seeing as how she's 36 weeks and she's not full term, they might send her home and watch this twice a week, have 3 times a week maybe, have her come in, do blood pressures in the office, and check serial protein creatinine ratios. So that's basically what you would do in an assessment for a preeclamptic patient. Do you have anything to add to that?
If they are preeclamptic, they're on fluid restrictions.
That's right. So I wouldn't necessarily get her a whole bunch of water right now. If she is diagnosed, we'd probably be starting magnesium sulfate. We would be doing a lot of different things. And they would give you an order, physicians would give you an order for how much fluid they can intake And usually it's like, we keep it like 75 mLs an hour or below. All right, that's that. Thank you.
Good job.